Good afternoon, everyone, or good day for those out west. My name is CB, and on behalf of the National Courting Center for PBRN and PHSSR here at the University of Kentucky, we would like to welcome everyone who's logged on today to join us in our Public Health PBRN monthly virtual meeting. And we're delighted to have our meeting today highlighted by the Research in Progress presentation by our Colorado Public Health Based Research Network. And before we get to them, we'd just like to make some announcements. And I'd like to first ask everyone, as a courtesy to our speakers, to please don't forget to mute your computer speakers or your telephone speakers. So I guess we're ready to move to the next slide, Kara. Thank you. So to start it off, we'd like to turn it over first to our director, Dr. Mace, to just give a few words on the successful granting meeting that took place, and also maybe to say something about the launching of the directive projects that are beginning next month. Dr. Mace, you have the line?
Hey, yes, thank you. Again, thanks for everybody to be with us today. We had a great workshop last week here in Lexington with a little bit of end of year monies. We were able to bring in representatives from most of our PBRNs around the country, at least those PBRNs that have active research in the IMPROVE and or the DAX research initiatives were able to come in and join us. And we also had some other PHSR investigators who are doing similar work in the cost and value and implementation science stream of PHSR also join us. And I thought it was a very productive 2 days. We spent the first day hearing kind of updates on findings from these projects with an eye toward thinking through what some of the emerging policy implications were from the work. So focusing more on implications. And then day 2 of our workshop focused heavily on the PBRN IMPROVE and DAX research efforts that are underway, and focusing in on what we're learning from a methodological standpoint around how best to measure and analyze variation in implementation of public health strategies, and also how best to measure and analyze variation in cost and resource use around public health strategies. So overall, a very successful and useful workshop from my perspective. Thanks to all of you who freed up some space on your calendar to come back to Kentucky and join us for a couple of days. We'll be packaging and disseminating some of the most salient implications and from that work in the next in the coming week. So stay tuned. But again, thanks to everybody who made time for coming out. I think what we may do. Do you want me to go through these other agenda items now? Is that the pleasure of the group, or do we want to hear from Colorado first?
Yeah, we'll cover first the agenda items, Dr. Mace, and then we'll hear from Colorado.
Okay, all right,
okay.
That's fine.
Yeah.
So couple of other updates. On a dissemination front, what's mentioned here, we do have a panel that's been accepted for the upcoming APHA annual meeting that's going to focus in on some of what we're learning from our research around studying variation in public health implementation and studying variation in public health costs and resource use. So a panel really devoted to several studies from our IMPROVE and our DAX portfolios of PBRN research projects. That's been scheduled for the morning of Tuesday, a pretty good time slot as far as APHA goes. Most people tend to still be around during that time frame. So we'll be thanks to those of you who scrambled to help us put together abstracts, and for that panel session. It's a session that's being jointly sponsored by both the medical care section of APHA as well as the health administration section, because these studies that we're doing obviously have implications for both the health and healthcare sides of our system. So put that on your calendar if as you're starting to think about APHA. We will be putting together a call of the panelists for that work here over the next couple of months for us to strategize on how to specifically how the panel will play out and to share slides and that kind of stuff as we get closer to the meeting. So, but again, thanks to those of you who helped us put that together. We're excited about it. Some other on the dissemination front. Another thing I'll mention that's not on this slide here, but we are continuing to work closely with another arm of APHA, and that is the American Journal of Public Health, on a special issue, special supplement issue devoted to advances in PHSSR. Many of you will remember the open call for papers that we had issued in conjunction with APH earlier this year. That work is continuing to move forward. We got about 130 submissions of empirical papers in response to that call. Most of those papers are still working their way through some stages of the peer review process. So for those of you who submitted papers to that, if you haven't heard already yet, if you hadn't heard back from feedback from the editors or from peer review, you should be shortly. We're about halfway through that process. About half of the papers have been through peer review already. Others are still in some process. But that issue is on track. We're guest editing it. And I think it's shaping up to be a very, very good issue, where it's being supported partly by the Robert Wood Johnson Foundation through our coordinating center, and also we got a supplemental award from CDC to help us publish an even larger issue on this topic. So we'll also have commentaries from both RWJ and CDC that will go into this supplement as well. Target date for release is May 2015. The electronic version of the journal should be available by April, in time for our annual Keeneland Conference in PHSSR. So thanks again to everybody who has worked hard on manuscripts for that special issue. We also have a new cohort of PBRN studies that are launching this month. The 4 directive studies are officially launching this month, and so we're very excited about that. We had kind of a soft kickoff meeting for these projects last week in conjunction with our work grantee workshop, but we're very excited about the directive awards. Many of you will remember writing your proposal and applying for this opportunity with a limited solicitation for research projects just from among the PBRN family of investigators. These projects all had to be developed and implemented through consortia of multiple public health PBRNs. So we're continuing to learn and get better at how to organize and conduct studies with larger numbers of practice settings and involved in multiple PBRNs. The 4 awardees, which will be disseminating more information about these projects in the coming weeks, but the 4 awardees include a consortium between Massachusetts and Connecticut PBRNs, a consortium between Colorado, Nebraska, and Kansas PBRNs, a Northwest consortium between Washington State and Oregon, and it seems like there's one other player there, but I'm doing this by memory. So there's a Washington, Oregon consortium that may also involve another PBRN that I'm blanking on now. I apologize. And the fourth awardee is a consortium between the California and Alabama PBRNs. And so very exciting work that will be playing out. These are multi-year awards helping to bring together methods from both the IMPROVE projects measuring implementation and the DAX projects measuring cost and resource use, and bringing those 2 sets of measures and methodologies into projects to look more comprehensively at the value of public health services and public health delivery systems by analyzing both variation in implementation and variation in cost. So very, very exciting work that we're excited to see launch this month.
All right. Well, thank you so much, Dr. Mace, for just updating us on also the directive projects that are coming up, and for the APHA panel, and for the opening remarks on the successful grantee meeting that we had. And I'd like to ask Kara to just assist me, since we have online also some of our Academy Health Scholarship recipients, teach back. And if you're online, we just go through what your name's on the slide, just to share, just very short, just share your experiences um, with your time at Academy Health and with the scholarship. Kara, do you know who's online right now, or who can speak? We'll just do it. We'll just follow the sequence of the names.
Actually, Stevie, why don't we go ahead and let Colorado present and maybe wait for some people to come online? I'm still waiting for 2 or 3 people. So
Oh, okay. Okay, no problem at all.
Time, we can go ahead and let Sarah and Adam present, if that's okay.
Sounds great.
Okay.
Adam and Sarah, are you ready to present your research on the public health services measurement?
Yes, we are.
All right. You have the line. Thank you for your patience.
Awesome. All right. Well, thank you all for allowing us to come and talk. So this is Sarah Lampy from the Colorado Public Health Practice-Based Research Network. I'm the project manager for all of our projects that we have ongoing right now. And I'll have Adam introduce himself quickly.
And I'm Adam Atherley. I'm at the Colorado School of Public Health, and I'm the academic piece of our partnership.
Awesome. So we're going to talk a little bit about a project that we presented briefly on the last time we presented to this crowd of individuals, to the public health PBRNs. We talked about what we call our core services project, but really looking at public health service measurement at the call last September. We were in the very early stages of analysis at that time, and at this point have gotten through a lot more of analysis and done some reliability and validity measurement within that. So we wanted to kind of update you on where the project has gone in the analysis, the approaches that we took, and also to talk a little bit about the reliability and validity. So that's what we're going to talk about today. I'm going to start by giving a quick overview of the project, of what we're going to talk about today. So I'm going to give you a little bit of background, talk about the measurement, go through the analysis results. Adam's going to talk you through the validity and reliability, and then we'll hopefully have time for questions and discussion at the end. And if you have questions that come up during the presentation, I typically say interrupt me, but I have a feeling in this format it might be better just to type them in the chat box or prepare them for the end of the discussion or the end of the presentation. So, as many of you might know, back in 2008, Colorado passed the Public Health Act. It did many things to reorganize local public health structure in the state of Colorado, including standardizing the legal structure, minimum qualifications of our public health directors, required that agencies do community health assessments, community health improvement plans every 5 years. But for this project, the most important right now is that there needs to be a rulemaking process for the promulgation of core services. So a rulemaking process was done in October 2011, and the following were core services that were promulgated into rule. Now these are broad core service areas. There's actually a lot more detail within each of these in the rule. So assessment, planning, and communication is the large core service, but within that includes community health assessments, improvement planning, communication, within communicable disease prevention, investigation, control, for instance, immunizations, and surveillance of different communicable diseases. So though this allowed us to strike a midpoint between only providing the 10 essential services, which wasn't enough for some of our agencies. That if you don't tell me to do immunizations, my Board of Health, which most of the time are county commissioners in our state, or elected officials, if you don't tell me to do immunizations, they're going to tell me not to do immunizations and cut that from my budget. So we needed to strike it somewhere in between to allow the ability for local control, but also allow for some still some guidance from the. So what we really wanted to do, the whole purpose of the project was to do a measurement of the core service rule and post core service rule. So we did a pre-measurement that happened actually before the rule put in place and before this research project actually existed. And we did it in partnership with the Office of Planning and Partnerships, as it's titled at our state. It's often called the Office of Local Liaison in most other state health departments, where they require an annual report from their local agencies every year. And we tapped into that ability to be able to. They this year collected in the pre-year baseline collected a large swath of information, and so we were able to help with that collection and then also use that as the pre-measure. So as we all know, the nature profile gathers basic information about service delivery. And here you'll see it says nutrition, who does it, it's contracted out by the local health department, et cetera. It doesn't provide as much detail as the Office of Local Liaison really wanted to prove that agencies were doing core services. On a little bit of a side note, the purpose of the baseline was not to collect, was not for a research project, as I mentioned. It was mostly to provide the data and information necessary to show to the political process that putting core services into rule wasn't necessarily an unfunded mandate. It was showing that most public health departments actually do these core services to some extent and to demonstrate what that meant. We heard from a lot of our agencies that what the nature profile collected, this amount of information, so just saying whether you do nutrition was not sufficient enough to really collect as much as they do. So some agencies could say that they did nutrition in this case, meaning that they went onto a CDC website and printed off a pamphlet about nutrition, where others were doing full nutrition campaigns that include coalition development and building and working on access to healthy foods in their community. So we wanted to collect a little bit more information than this. So we went to the other extreme of instead of collecting just a little bit, we collected a lot. So you'll see here where we say nutrition, we also asked, do you have education materials, media, cultural linguistic materials, programs, all the the swath of potential things that agencies could be doing within their core service delivery. So when it came, so this is what the baseline review tool looked like, and it really got out a large amount of information from agencies. Our follow-up instrument looked a little bit different in that we were able to, it's essentially the same information, but was structured in a way that our agencies preferred. So we listened to what they had said about the way it was structured in the previous instrument and followed up. The biggest thing that changed between baseline and follow-up was through the wonderful guidance that we had received from the Improve project from the National Coordinating Center. We followed a similar modified Delphi process to determine which measures were the best measures to follow up with. So we couldn't collect as you can see here, we had originally somewhere up to almost 2,000 measures that were collected in the annual report from the initial start of the project. We couldn't collect all of those. So through our project advisory committee, experts in the field, and several other practitioners, we've moved from 1,800 to 360 measures, which is still a lot, but a whole lot less than what they had been asked about in the first go-around. And you'll see within each of the core services, we limited it down quite a bit. They mainly wanted to talk about our analysis methods within this webinar, so gave you a lot of that information as more background to understand where we got to the measurements that we got. And the analysis piece is where we looked at the fact that we had 360 measures, and within those measures we had degrees of measurement. So as a reminder here, you'll see we asked about tobacco, but we didn't just ask about tobacco, we asked about tobacco materials and tobacco media and tobacco development or dissemination, and tobacco fell within chronic disease prevention. Chronic disease prevention fell within prevention population health promotion as a core service. So we thought about how are we going to determine the changes in core service delivery. Do we roll it all up into the larger core service? So you'll see here on this slide, the larger core service of prevention population health promotion. If we roll it all up into that, then are we really going to get at the smaller changes that agencies are making that could be significant? So we started looking into, well, what is the best way for us to start thinking about this so that we can capture some of the smaller changes that our agencies feel are very important, but also still getting at that larger question of, are there changes in local public health service delivery after core service implementation? So I wanted to lay this out so you get, and this is just an example. So in the example of core service of prevention and population health promotion, we had 3 different program areas, and within those we had different service areas. Now each of those service areas also had activities. So there is a lot of detail in this information, but hopefully, so what we decided to do in our analysis was to analyze at each of these levels. So we looked at looking across all of the activity service areas and program areas, what is the change of core service overall in prevention population health promotion? In the program area, we looked at chronic disease. So how many activities were agencies doing pre and post within all of these service areas of chronic disease? Then we also looked at the service areas and we said, how many of these activities, number of activities are agencies doing in each of these service areas to see if there is a change in activity numbers between pre and post. We also turned it a little bit on its head, but I'm going to get into that after I show you a little bit of the results. And this is a lot of information, but what this shows you overall is that, and you'll see the different colors of areas in the graph or in the chart show you those are the different core service areas. But so for each of the core service areas, we looked at the range of activities that each agency could have been involved in, and we did a pre-test and post-test mean and did a t-test for the comparison of means to see if there was significant changes within the core service areas. So if you, just a brief glance at this, the only overarching core service area that had significant increase in number of activities was communicable disease. But the most important thing that we ended up finding out is that getting into the detail is where it gets important, and that's where you can start seeing some incremental changes that agencies are making. So I'm not going to get into details with these, but I just wanted you to see these charts a little bit closer up. But to see communicable disease, there were overarching core service of communicable disease was significant, but not everything within it was. However, within the program area of population prevention and education and influenza, there were 2 areas there that did have significant increases in core service delivery. Again, within prevention population health promotion, if we hadn't started looking into the details of what each agency was doing across these service areas and program areas, it would have been lost. We wouldn't have thought that anything was going on in prevention population health promotion. But in fact, there is significant changes and significant increases in the number of activities agencies are. And environmental health, we had some changes. The only one that was significant was summer camps, though the core service of environmental health was, close, moderately significant. I'm going to roll back to this table again because we then decided, well, we want to look also at changes in activities. One of the hypotheses going into this project was not only that we would see changes in particular service areas or program areas, but that we would actually see an increase of the number of agencies moving towards population health activities. So more of the policy development, community development side as opposed to the individual education materials, education programs type stuff. So therefore, what we did is we kind of turned it on its head, and we said we're going to start from on the right of this graph of this chart and say, of these activities, how many service areas had an increase in or increased their work in those activities. So it's maybe a little bit confusing, but it allowed us to look at the activities and how activities are changing overall in the local public health agency. So again, a busy chart, a busy graphic, but what you'll see is that we again have some activities that we're seeing significant increases. And what was really interesting to us were that the activities that saw the most significant increases were the ones that were much more what we would consider population-based. And I'll get into the details of those within each of the core services. So, for instance, communicable diseases, the activities, we had to categorize some of our activities within communicable diseases because of the individual activities that happen within each of the areas that were, the program areas or service areas that were. The details of that are in here, but in reality, what really came out, and we recategorized these even before we did the analysis, so I had no idea what was going to come out. But what we see is that our system-based services, which include tracking and follow-up, checking registries of immunization, monitoring coverage rates, prevention of disease transmission surveillance, community development, and policy development, we saw a significant increase in the number of agencies who were doing that kind of work across all of the potential service areas. In prevention population health promotion, within these activities, the areas we saw the most significant increases were in cultural programs and specifically and in policy development initiatives. So again, especially the policy development, a much more population-based and not necessarily a individual-based activity or approach for addressing the service areas. In environmental health, again, outreach and education was the area that we saw the most significant increase in activity. So we also did an analysis on the structural factors to get an understanding of whether different structural factors of local public health agencies modify the results. And we looked at, after doing a lot of key informant interviews, discussions with our project advisory committee, we came up with these 5 that were the factors that they all had thought might be some good ones to look at, and that might modify whether there are changes. They include local board of health structure, structure of agency prior to the act, agency leadership turnover, jurisdiction, population size, and percent of population living at or below poverty. So, and you'll see, I wanted to draw out a little bit of the numbers. So when you look at this, you'll see that we have a fairly good number of agencies that fall within each of these different areas. So the particular one that was when we talked to people about it, they're like, there's no way that executive director turnover can be that, you can have that many. And even since we did this analysis, we are up to about 50% of our local public health directors have turned over in the last 3 years. So it's significant in our state right now. We have a lot of turnover of directors, so we wanted to look at that in terms of whether it really changed how service delivery was happening. So you'll see here that as far as significance is concerned, not many of these were significant. Not the only one that truly showed significance was in communicable disease services around executive director turnover. And knowing that we continue to have a lot of turnover, this is something that we think about quite a bit when it comes to service delivery change. I don't have a whole lot more to about that. So the key findings that we had from this is that even in a short period of time, we only had 2 years between baseline and follow-up, we did see some significant changes. We would like to continue to look at doing some service delivery measurement data collection such as this so that we can see over time how our service deliveries shifting in local public health agencies. We know that a 2-year time frame is not really great. You're not going to see the most in the and some of these changes could just be based on chance. But in reality, we still saw some significant changes in years. We were really interested to see, as I mentioned before, those significant increases in population health activities across all of the 3 core service areas that we dove into. What I didn't mention, and I should have mentioned before, is the other core service areas that were we did measurement on were not included in this analysis because of many different factors that were affecting how those services were being delivered. So, for instance, we didn't actually do analysis in the assessment and planning because of the requirement that was in the act outside of the rulemaking that required that agencies do community health assessments and community improvement plans. It modified the responses that we got tremendously that we didn't feel confident that the rule itself was what caused the change. There are examples like that across the other core service areas that required us to really stick to these main core service areas. One of the other significant changes or things that we saw that was of significance to us was that we saw significant increases, but we had no significant decreases. So we essentially, for us, and we interpret that, and so do our local partners, that local public health agencies are taking on more and not letting go of some of the work. So they're continually taking on more work without giving up some of the other work that they have done. We did see some decreases, but they weren't significant. And I'm sure if we keep measuring over time, we might see more significant decreases, but at this time there were none. We heard over and over again that they thought that changes would be due to local public health jurisdiction size or governance, but in reality, when we put it into a regression model, those actually were not factors. And one of the biggest key findings is that that detailed data collection that we did was very cumbersome. It took a lot of time and effort for us to think through what's the best way for us to do this to ensure that we're actually responding to the research questions we had at hand while also still getting adequately representing the data that was provided. So though it's cumbersome, it was absolutely necessary for us to get that kind of detailed information for us to see those incremental significant changes over time within our local health department. So I'm going to pass the mic, I guess, hypothetically, over to Adam to talk about reliability and validity.
Thanks, Sarah. That was a great summary. I actually just lost my connection. Is it just me?
I still have mine. Do you have the slides? Could you go?
Yep, I do have the slides. So.
Okay, so why don't you?
All right, there I'm back. Okay, good. Okay, so as Sarah did a great job describing the process and looking at the core services, one of the questions that came up as we're working through this as a research team is the question of whether or not these measures that we're looking at were actually reliable and valid. So could we go to the next slide? So the question we kept asking, so we have all of this data, and we think that this data, as Sarah has presented it, represents real changes in activities and not just changes in numbers. But that's really kind of an empirical question of whether or not we're measuring what we think we were measuring. So one part of this project is after we collected the data, we then went back and we tried to establish whether or not the core services measures were actually reliably and validly measuring what we think they're measuring. Could we go to the next slide? So just to remind people who are listening on the phone, our definition of reliability and validity, again, the reliability question is if you ask the same question in the exact same way under the same circumstances, would we get the same answer? So we're not asking whether or not the question is measuring what we think it's measuring. We're just asking the question of whether or not we can get a consistent answer back from the person who's answering the question. For validity, we are asking that question. We're asking whether or not the numbers that we're collecting actually represent differences in activities and services provided the way that we think it can. And so again, to be able to use this data to actually guide us in policy, we need to be able to be confident that the measures are both reliable and valid. Could we go to the next one? Okay, so for the reliability, what we did was we did test, retest. And let me sort of go as an aside, a commercial here is that we think this is a really good activity that can be done on a lot of these kinds of projects that we need to, as a field, worry a lot more about whether or not the way that we're asking questions, that we're actually doing this in a way that is reliable and valid. And so this is something we did as an extension of the project that we think could be done in lots of different projects. And I think the more data we can get as a field on the reliability and validity of the measures, the better off we are. So for the reliability, what we did was we took 19 agencies, and then we essentially sent them, we picked some selected measures. This is, as Sarah described, this is a huge instrument, and it's incredibly time-consuming to fill the whole thing out. So we picked out selected sections of it, and 2 to 4 weeks after we got the survey back from the agency, we resent it to them and asked them to do it again. And so again, we had selected measures across a number of the different domains to get an idea of what kinds of questions we could get consistent answers from. The second thing we did was we looked at the validity question. So for validity, we did construct validity. And what we did is we looked at the NATO profile data, and we tried to find questions that were similar, although different, in the NATO profile that we thought we should see consistent answers across. If we go to the next slide. Here's a couple of examples of the way we did the validity piece of it. We looked, within the core services project, the questions asked about the structure of the agency. It said, please select one of the following to describe your local public health agency, and one of the options is a single county agency. In the NATO profile, they ask which of the following best describes your local health department's organizational structure, and one of the options is my LHD is a freestanding public health agency. So we should, even though those questions are different, we should see consistent answers across them. And we found a whole bunch of measures within NATO that corresponded in this way to what we were asking in the core services. And so then we were able to look at the correspondence between the answers on the two surveys, and we should see similar answers across the surveys. Now, we had 144 different measures that we were looking at the reliability and the validity of. So there's a huge amount of data, and we could very easily have used up this whole call just talking about reliability and validity, but I think the emphasis here is really on the results of the core services project, and this is, again, this is an add-on, so just something we want to say in addition. But in terms of the reliability, we actually found some fairly consistent results. That if you look on the right, we have the reliability number, and essentially the higher the number, the better off you are, with 1 being the highest number. So when we asked questions about administration and governance, we had 6 different questions there. We essentially got perfect agreement on that. On the other hand, where we started to get very inconsistent answers back from the agencies were in 2 areas. One is on capacity, that's again in red there. We had 9 different questions on communicable disease capacity, and that is a very low reliability number. That's not much better than chance. That's in the range where you have to sort of ask questions about whether or not the number is really meaningful. The second is in the area of assessment and planning, where again we get quite low reliabilities. But you can see that in general, the reliabilities are in the, I mean, a lot of people think in the 0.6 and 0.7 range, that's sort of an acceptable reliability. It kind of depends on what you're trying to do. Okay, can we go to the next one? In terms of validity, and we're just going to kind of give our summary of what we see in this area, when you ask questions about funding, services provided, inspections done, those kinds of activities as performed by the local public health agency itself, we saw very high levels of agreement between the core services questions and the nature profile questions. Where we saw very low amounts of agreement is on measures about what happens elsewhere in the community. So questions, for example, asking about so in other words, if you ask the local public health agency, do you do these services? That seems to be a question they can answer really well. If you ask them, does somebody else in the community do these services? Those questions we started to see much lower levels of concordance. And then if you ask the question of whether, depending on how you want to phrase it, you could either say, is this not done by anyone in the community, or is there anybody else? That's where you start to get really low rates of agreement. So when we look at our conclusions, and we go to the next slide, what we find is that when you have measures asking about the structure, funding, services provided by the local public health agency itself, we saw very consistently very high reliability and validity. When you start to ask questions about capacity and you start to ask the public health agency to project into the future, for example, questions like, do you think the funding level next year will be higher or lower than this year? You start to get reliability problems. In other words, you start to get answers that are, the data's coming back in an inconsistent way. And then when you start to ask questions about activities outside the public health agency itself, that's where we started to see the validity concern.
All right. Well, thank you, Adam and Sarah, for that wonderful, insightful, informative presentation. We will now open the lines for questions, and we can start with questions from either chat box, or just feel free to unmute your phone and just ask the question through the phone or speaker. Or let's start with Susan. Has a question. Were there any changes in funding associated with the law change or the time frame?
So that's a great question, Susan. We looked at, we actually did ask funding within each of the core service areas, and we got such terrible answers. And I say terrible answers in the sense that some people just left it blank in baseline. So we got great information and follow-up, but we didn't have comparison in the core service areas. Now, we do have overall funding, and we compared overall funding from baseline to follow-up, and they are within 1% of each other. So overall funding for local public health agencies did not change significantly from pre to post. Any other questions?
This is Scott Frank from Cleveland in the Ohio PBRN. I think you've done some incredible work here, and kudos to your local health department members for going through this process with you. It's more of a comment than a question, but I'm struck by the extent to which, despite the detailed look that you took and the efforts you made to winnow down the number of items, you still have what appears to be a very different set of service areas around a program area of chronic disease than we might have here in Ohio. All of those might be included, but access to care, chronic disease self-management might also be parts of those program areas that we would have in a very central position. And it just makes it frustratingly difficult to make comparisons across states, much less within states, about what is considered core service, even within areas that we try to use to narrow those differences.
It's a great comment, Scott. So one of the things that we also did was there were, in the baseline, they had, and this was, again, it was outside of research done fully by what our practitioners had said at the time. They had divided or separated out what they called direct service areas. So chronic disease self-management was in that, as well as access to care, what we call EPSDT care. So those were categorized and asked differently in baseline. So we were then forced to categorize and ask them a little differently in follow-up. And so unfortunately, we don't have as much detail on the service delivery within those areas, though they were considered part of chronic disease and just asked differently and put in a different place. So we have information and data on those, just it didn't fold nicely or even work really well in the analysis that we have here because the collection was so different. So it's a great comment and just one of those things, again, where state by state, it's just a little different.
It just shows how difficult these things are, the degree of complexity. So, for example, my impression, and I don't have a research validation of this, but my impression is that chronic disease self-management is a growth area, and that if that had been included here in Colorado or Ohio, that it probably would have been a significant change and would have then further affected the change for that whole area of prevention and health promotion and chronic disease. So, we do complex and difficult research that does constantly change, and it does just make interpretation difficult and knowing how to compare, as each of us has said, across states. But I think this is really interesting and terrific work, and does sort of validate that need to drill down rather than be general in our approach.
Thank you. Agree.
Are there any more questions? I think one way to end the discussion would be to ask Colorado how, what's the plan moving forward in terms of how we'll use the results in informing policy, or I guess with regards to measurement reporting in Colorado. Is there any, I guess, dissemination activities right now, the results?
Yeah, it's a great question. So we're presenting this information at our statewide Public Health Association meeting, and in September. So that's one dissemination place. We're presenting to the State Board of Health hopefully in November or December of this year. It takes quite a bit of time to get on their agenda. To be able to report back what changes we're seeing in core service delivery. We've done a lot of dissemination with our state health department. They're going through a lot of changes in their own collection of data and information from the locals across many of their divisions at the state health department. So we've done a lot of presentations and conversations with people within the state health department to talk about, well, here are the measures that we have, and here's the extensive amount of research that we've done on these measures to get an understanding of what and how to ask best best asked questions of the local agencies, and also to hopefully get them to not over ask agencies the same questions we've already asked them. It's one of the big things that we want to make sure happens. One of the other things that's come out of this has been, it's a little tangential, but it also is really great, having all this information about our local health departments and what they do and how they do it has really helped in our conversation about the connection between public health and our ACOs in Colorado, which we call RICOs, and what kind of relationships can be built between them and the ACOs and also within the payers, and how can we better approach payment of public health agencies and all the work that they do, and what are some new and interesting activities that public health agencies do and could bill for and get paid for that currently they're not getting paid for. So there have been conversations around, there was a white paper written using a lot of this data to be able to say, you know, here's what public health agencies do, and here's what they are and are not billing for, and to the ACOs, here's what public health agencies are doing, and what are some ways that you could see partnering between the two of you to start moving forward in the best way possible for your community members. So there have been, and those are just some smaller examples. There have been a lot of examples that have happened within our state around the use of this information. And we hope that we continue to move it forward so that we have a lot more conversations like this. And I forgot that Julie Marshall's on the phone. Julie, did you want to add anything, or she was part of this project as well? She can't.
Okay, I think she's typing something right now, but she's on the chat box. Oh.
All right. Well, those are just some examples of how we're using this moving forward. Great question.
Excellent, excellent. I think the results that you presented are, of course, novel, and it would be really interesting to hear, you know, the feedback once you get to present it to the state board. And there's just going to be a lot of use for it, and we're excited. And I think later on we could catch up where Julie's still typing on the chat box, but we'd like to thank again our speakers for this webinar. Adam and Sarah, thank you so much for your time and for sharing the results of your study. And I think Julie just typed something. An additional use of the baseline capacity assessment has been to engage other researchers, indeed. And I think there's a lot of opportunities for the data as well for further analysis, I would imagine. And so
Absolutely.
Once again, yeah, thank you so much, Colorado. And we look forward to hearing more about how the results and the data have been used in practice, especially in informing policy. So excellent, excellent. I think we now have time, Kara, to go back again to that second slide with just to hear some of our Academy Health Scholarship recipients just share a little bit about their experiences. I guess I'll turn that over to you, Kara, if that's okay. To call out them in sequence of how they're presented in the slide.
Sure, that's fine. I know that Gregory and Eli were not able to be on the call, but they did email in responses to the questions that Lizeth had posed to them. And question number one, she asked them that identify one key session, experience, method, or piece of information that you encountered at the ARM or the IG that you feel would benefit other PBRNs. And Gregory responded, the most rewarding experience that I had at ARM and the IG meeting was by far networking with other researchers and practitioners. And I feel that networking is the single most beneficial activity for people associated with PBRNs. Exchanging ideas and experiences with smart and motivated people that share work objectives has been hugely motivating for me. It has also spawned some budding collaborations that I am confident will continue to develop and grow. My experience has no doubt been influenced by the fact that this was my first time attending the ARM and my first significant interaction with the IG, but even for individuals that are more connected than I was, I feel that networking and the face-to-face exchange of ideas and experiences is hugely beneficial. And I'll just go ahead, the same question is Eli responded that I really appreciated the work of Dr. Timothy Brown on looking at the relationship between public health spending and mortality at the county level in California. I think this is an important body of work to build upon as local health jurisdiction budgets are under constant attack in an era of shrinking public budgets. As an epidemiologist, I would have loved to attend a methods workshop that would outline in detail Tim's work so that I can more easily implement it here at Public Health in Seattle and King County. Here at PHSKC, we're trying to build greater capacity around integrating analysis of cost data into routine epidemiologic surveillance. One example is our pending request for historical and current Medicaid claims data from the state Medicaid agency for the purpose of looking at trends and total per capita cost of care pre- and post-Medicaid expansion. Washington State is in the process of building an all-payer claims database, which hopefully will be leveraged to support this body of work. It might be worthwhile to hear from PBRNs in states that already have a robust APCDs, for example, Colorado and Vermont, how cost data can be successfully integrated into public health practice at the county level. So, and I think we have Jessica and Danielle from Academy Health on the call too, as far as to respond to the answer to the first question. Do you guys want to respond while I'm reading the questions, or would you just rather wait to the end?
Hi, this is Jessica. I'm happy to wait at the end
Okay.
just to see what all the feedback is, and then we'll formulate our thoughts. So thank you.
Okay, perfect. Not a problem. Just wanted to give you the opportunity. And secondly, the second question was discuss a session, speaker, or presentation, or other activity or piece of information that you personally found compelling at the meeting. And Gregory responded, a recurring topic or theme at the meeting that I found compelling was the topic of nonprofit hospital community benefit activities. This was the research interest that I received the scholarship on. It was interesting to me to learn more about the work that others are doing on this topic. I continue to believe that nonprofit hospital community benefit activities represent a major opportunity for coordination and collaboration between health services and public health infrastructure, but that it is going to take a lot of work to realize this potential. It was reassuring to me to learn that many others see the potential and are working on this issue. And again, that was Gregory's response. And Eli's response was that I found Malcolm Williams' IG presentation on assessing organizational partnerships using Partner to be fascinating. King County, Washington is currently in the process of formalizing cross-sector health promotion partnerships through establishing an accountable community of health, which is in alignment with the Center for Medicare and Medicaid Services State Innovation Model Initiative. This work is based on the fundamental belief that due to the complex nature of the upstream social drivers of poor health and disparities cross-sector, cross-agency, cross-community infrastructure and strategies are essential in order to achieve the triple aim. With this in mind, I was intrigued by Malcolm's presentation as it showed the power of partner in looking at multiple facets of organizational partnerships. In a setting where cross-sector work will become more important and the impact of any single intervention or agency will become almost impossible to disentangle from the collective impact, tools like Partner could support local health jurisdictions to build an evidence base for this collaborative work. And then I know that I haven't seen Hillary or Colleen's login online yet. Are either one of you guys online or on the phone? Okay, if I don't hear from them, guys, if you're on the phone and just can't connect right now, we're going to go ahead and jump. I did see Beth on the phone and Rebecca, so Beth, we'll go ahead and move to you.
Great. Good afternoon, everybody. Greetings from Minnesota. Thanks for the opportunity to give you a few highlights from our Academy Health Trust. I do have specific answers to the two questions, but also just wanted to frame my comments that can kind of build on what Greg commented through his notes, that to go to the full arm, this was my first time going to that in the interest group. It really gave me, I think, a larger context within which to think about where our PHSSR research kind of fits, how it fits, where it might fit better. The networking piece that Greg talked about was really, really key, but also the opportunity to go with my academic partner, Rebecca Pratt, who you're going to hear from shortly, it really gave us an opportunity, I think, to spend time both at the sessions, and we kind of divvied some of them up, and we attended some of them together, and then kind of come back and talk about, what did we hear, what was kind of the different lens or frame that we heard it from. So for me, kind of that structure of those paired scholarships was really, really beneficial. In terms of a key session that might be a benefit or of interest to other PBRNs, I went to the Public Health Financing and Cost session, which had Betty Beckmeyer and Glenn both presenting. And, Glenn is probably too modest to ever say this, but, his presentation ended up being one of the best of the ARM presentations. So it was really elevated at the Academy Health meeting, and with reason. I think, as we start in Minnesota thinking more about how do we link our costs, our financing, our performance, really putting into the context of, the ACA is coming down the pike or is in place, are we, though, going to be losing some of our public health funding to pay for that Medicaid expansion? And will that result in perhaps lower population health improvement strategies? So I really suggest to anybody who hasn't seen Glenn's slides to hit him up for them or to go to the Academy Health website and see if you can't click through, because it was really, really interesting, and we've actually had him come and talk to a broader network of practitioners in Minnesota just because it was such a really compelling presentation. In terms of a specific session speaker presentation, for me personally, I really was coming to this with Rebecca. We're working with Colorado, Washington, Wisconsin PBRNs to look at the primary care, public health, collaboration or integration at the local jurisdictional level. So I found myself going to sessions that, did seem to kind of tap into where might primary care and public health come together. How is that looking across the U.S.? One of the ones that I think perhaps prompted from the day before listening to Glenn's talk was, what is public health's role in a post-ACA setting? And so it built on the session before, but really talked about, how might state and local health departments retain relevancy in a post-ACA world? And does public health really have that leadership capacity? So it was a great, but I will say kind of mentally exhausting week, but certainly appreciated the opportunity.
Thanks, Beth. Rebecca?
Yeah, hi. I'm Rebecca Pratt from the University of Minnesota, and I work here in a family medicine center. And it was a wonderful opportunity. I'm really grateful. I suppose this is my second to Academy Health. A little bit like trying to take a sip of water out of a fire to get there in terms of the depth of all the presentations. And what was really helpful for me was going along learning kind of here with Beth is that it actually it sort of really shaped me getting my head out of my usual route of my around PBRN to spending thoughtful time. That's a little bit of a reflection of the fact that Beth public health and integrate. So that the timing really could be better for me. So I got a lot out of going together as a just even with shaping the whole, was having someone debrief with and think. For me, that's really valuable because being in a very PBR, get those opportunities with help. So was in terms of sessions that were particularly useful for me. I suppose what I'm really attending sessions I might their perspective, their clinical such as but Ranak Trivedi talked super complex, really engagement to with the kind of needs. Really kind of small research making, and then kind of going to the conversations of the public, big numbers, grading public session chaired by Hector Rodriguez, which looked at some of the big numbers data, thinking about how these two really think too, just to kind of reflect on, add to what Beth said, that climate, there's change and how as opposed to about the potential of the health sector. So that was very useful. I think too the last thing would is what was personally attending the and see what that to do was just get really immersed. Conceptualize. That's a little bit different than say, and so to be involved in doing was really culture of the so that was so those are the main things that again for this wonderful that it really helped strengthen the Beth and I think that we're doing.
Thank you, Rebecca.
This is Anna, and I want to take an opportunity before we turn things over to our Academy Health friends and get their responses to some of these to once again thank them. This is the second year Academy Health has provided these funds specifically for our public health practice-based research networks to really engage in the broader annual research meeting as well as the IG, and I think it's been very beneficial both years. It's been interesting to me that we've heard a lot of overlap about what our PBRN folks have found particularly useful, but we've also had some interesting items that maybe fell outside of what you might initially think. So I think it's been very excited. I think it's stirred a lot of conversation, a lot of deep thinking about some of these issues, about the as Rebecca and Beth were talking about, specifically about the intersection of public health and primary, and I think that that's a really good conversation to be having at this time. It's obviously a big priority for a lot of people to figure out how those pieces can fit together as well as possible, and I think Academy Health has done a lot in helping us understand that process. I will promise you that we will try to find Hillary and Colleen and get their feedback as well on a future call. But that said, I think we'd really like to hear from our friends at Academy Health now.
So I'm sorry, this is Sarah Lampe. I actually got a scholarship, not listed on there. You still want my feedback?
Absolutely, Sarah. Jump right in there.
Sorry, I should have probably mentioned something earlier, but I had prepared what I was going to talk about, so I wanted to share. And I don't want to re-echo everything that's been said, but the networking is always spectacular. Greg Tung was my academic partner in this. However, Adam, who you heard present earlier, was also at Academy Health. And having the three of us there was really great for us to network within the Health Services Research Group. It's kind of Adam's bread and butter area, so he knows a lot more people that are at Academy Health. He has the inroads to a lot of people there that Greg and I didn't necessarily have. So we got to meet a lot of people there while just hanging out with Adam. You just sit next to him and he introduced me to like 5 different people who I'd seen present, which was great. So that, again, that partnership is incredibly important. I think Greg was, as he mentioned in his feedback, he's new to our work. He's new to Academy Health, and I worked really hard to try to introduce him to as many of the public health interest group people as possible. So I hope that he did meet and was able to meet a lot of people to create those connections within our research world, and hopefully we get a project funded with him very soon. Some of the presentations that I thought were impactful on my work, I'm going to harken back to Glenn's presentation, and that whole cost panel was incredibly insightful, helpful. There was, I don't remember the names of the other 2 people on the panel, but they were also very good and brought to bear some really good information that I have harkened on since going to the conference. And we've had a lot of conversations around that, especially within our DAX project, but also in just the broader theme of cost of public health spending. I also enjoyed being able to have conversations with the Minnesota colleagues about our project. So Betty was there, Susan was there, I was there, and the Minnesota team was there. We could talk about our public health primary care project in person, which was great. It was also great for us to think about that in terms of the other presentations that were going on at the ARM. There were a few other presentations that were impactful. There was a presentation on the SIM projects. One of the people from Colorado actually presented on ours, or not on ours, but presented a bit on our ACO Public Health Connection. It was insightful in that it was what we often don't hear from our public health lens is what our ACO primary care colleagues say about their connection to us in the crowds that they typically talk in, not when they're talking to us. It was good to hear from their perspective how they think our partnership is going, and what ways they think of public health outside of the work that they do with us and our locals directly. So that was really interesting and insightful. I also went to one methods presentation on dissemination implementation research on the consolidated framework for implementation research. It was just a nice presentation to kind of frame or think about dissemination implementation. I've done some research into it and hope to continue to think through some other D&I work related to that presentation. That's all. Thank you.
Thanks so much, Sarah, and I apologize. I'm not sure how you ended up left off the list there, but thanks so much for jumping in. Is there anyone else who attended Academy Health who'd like to share a few comments before we ask Jessica and Danielle to chime in? All right, hearing none, it would be nice if we could have a few words from our friends at Academy Health, and once again, thank you all so much for providing this opportunity.
Absolutely. So thank you for the opportunity to speak with everyone. This is Jessica, and I'm joined by my colleague Danielle, who's in the room with me. And I'll start off by saying Kate Papa regrets that she cannot be on the call today. She's out of town, but Danielle and I will, of course, circle back with her as soon as possible to let her know about the great feedback that we heard on today's call. So first off, thank you to all of our wonderful recipients who not only really helped us out by accepting the scholarship and doing the pre-work that we administered before the ARM and the IG meeting, but once again helped us by completing our post-meeting survey as well as joined the call today and told us, again, the great feedback that you all have. All of the work you do really helps us define the program, and as was mentioned, this is our second year. So even more so than a fully defined program, your feedback is taken seriously, and we look at it critically. So thank you for, again, providing some great comments for us. And there's kind of two notes that I wanted to pick up on, as well as one call for assistance that I'll say at the end. But the first point that I think was really fascinating to hear was the fact that working in pairs was such a huge contribution to your learning experience. And I think, internally, this is an idea that we're going to possibly continue, most likely continue in years to come, since our second year has shown us that the pair concept is really beneficial in terms of networking, as well as being able to split up meetings and sessions, make sure all the bases are covered, and to really be able to have some active dialogue at the ARM itself, as opposed to waiting to the end to do all of the digesting and regurgitation of information. So thank you for your feedback on the ability to work with your pair. And secondly, we really enjoyed hearing how some of the sessions and the topics which are most useful to the PBRNs are those that, although they may be directly related to public population health, they are often given a different label at the main arm, since there are so many sessions and so many topics. So the ones we've written down are, a lot of method sections, things on data, specifically APCD data, which is something we will keep note for 2015. I really love the comment about the intersection of primary care and public health, and then translation and implementation and dissemination. So those are good for us to keep in mind, because as we continue to develop the program, we can maybe suggest sessions that fall under those themes that may not jump out to those who are just looking at our agenda as of interest to PBRN. So we will continue to keep that in the back of our minds as we look towards next year. And then finally, there's been a lot of great recommendations for what information would be useful moving forward, and it's never too early to tell us your ideas for sessions. As you know, the ARM is largely abstract-based, so the content, the sessions, the format of the meeting is really dictated by the research that we receive. With that said, there's always an opportunity for us as the population and public health staff to add our guidance and loosely influence. So if there is a specific topic that you would be jazzed about seeing, please email me, myself, or Danielle, or Kate, Danielle, and Kate, and we will go ahead and see what we could do with your idea, if that makes sense. So we would love your feedback now, and it's never too early to help us with 2015, because believe it or not, it is around the corner. So I'll pause there, but I think our overall comment is thank you. Thank you to all of the great scholarship recipients. If there's anything else we could do for you to help continue some of the relationships started, feel free to let us know.
Well, thank you so much. Do we have any questions or comments for our friends from Academy Health while we have them on the line? Hearing none, we'll move on with the rest of the program. The presentation schedule you can see in front of you right here. Coming up in September, we have comments from our Ohio Public Health Practice-Based Network. Then we have New Jersey in October, Washington in November, New Hampshire in December. As always, if your group is scheduled to present on a date that for some reason a conflict has arisen, you are more than welcome to speak with one of the other folks who are scheduled to present the rest of the year and work something out. We just need to know at the coordinating center if there's a switch. All right. And now I have a share my screen image. All right, is there anything else that we need to cover while we're on the line here?
Hey, Anna, this is Glenn again. One thing I thought we might mention, many of you have probably already gotten some notice in the email, but just to call it out here, another great initiative that Academy Health is leading for us is this recently announced call for dissemination in translation success stories. And Anna, do you want to say anything more on that, or?
I know that Academy Health is always looking for opportunities to highlight our PBRN's work and public health services and systems research work around issues that we've been able to actually have some effects on policy or some effects on practice. So if you have some examples of opportunities that you have taken to do exactly that kind of work within your PBRNs. I know sometimes we hear about those things through reporting, and sometimes we don't. Sometimes they just happen, and folks just forget about how important they are when it comes time to report, because you've got so many other things around budgets and spending and exactly what your findings were, that those things sometimes fall through the cracks. So we would love for you to share those experiences with Academy Health as well as with the National Coordinating Center. We are in the midst of finishing up, putting the last touches on the website and giving it a nice spit shine to get it going in the next week or two. And we would love to have stories of yours to share when we have that up. So please, if you send stories into Academy Health, by all means, share them with us as well. Blind copy us or carbon copy us so that we can see what's going in as well.
August 29th, I think, is the deadline for Academy Health. We'll make sure we'll circulate that through our electronic newsletter and other formats. So if you haven't seen that come through your email directory directly, we'll relay it to you through our channels.
Yeah, thank you, Glenn, for bringing that up. We are very excited, and I'll just want to add that no success story is too big or too small. So, we are not expecting a huge, mountain has been moved, but really anything from you created a one-pager that was read by person X and person X decided to do something, we would love that nugget of information. So please keep us in mind.
And I'd also like to remind folks that we are on the PHSSR side of the Coordinating Center right now. We do host regular Research in Progress webinars. We have a Research in Progress webinar coming up next week on the 27th, looking at the cost-effectiveness analysis of a fungal meningitis outbreak in the New River Health District. So we have that coming up on board. That is next week, the 27th, from noon to 1 p.m., and we do have a whole series of those. You should be getting regular announcements about those, and if you're not, let us know. We want to make sure that you have the full list. Is there anything else that we're missing here? Let's see. We do have, yes.
This is Scott Frank from Cleveland again. Another Academy Health related thing that I just wanted to mention. I've been invited to participate, as others might have as well, in a mentor-mentee relationship around PHSSR dissemination. I am pleased to be in the mentee role, learning more about how to effectively disseminate the work that we're doing. So I appreciate the opportunity from Academy Health and look forward to seeing how this process goes.
Thanks, Scott. This is Jessica. We're looking forward to working with you as well, and I will be in touch with next steps. So thanks for joining us.
And I will also mention that I recently got a call for abstracts, and if this hasn't gone around yet, Tara will make sure that it does. For the Citizen Science Conference and Gathering in 2015, if any of you are working in communities in a way that falls within that citizen science domain, and much of PBRN work does, as you well know, that gathering is going to be in San Jose in February. And we will make sure that you get the call for abstracts from that. They have a number of ways of participating, from posters and storytelling to speed talks and longer talks and symposia and panel discussions. So we'll make sure that that gets in your inboxes. All right. Are there any other questions, comments, items we need to cover for the good of the order, so to speak? All right, hearing none, I think that you all have just, oh, one moment please. I do have in front of me the call for dissemination stories that Glenn just mentioned, and we will make sure you get that as well. We will send both out. If there are no other issues, going once, going twice. All right, you just found 6 minutes in your day. Use them well. Thanks so much, everyone, for being on the phone. We appreciate it, and we look forward to talking to you all next month. Have a good evening.
Thank you.